This conference will now be recorded.
All right, folks, so we have chapter 10. This is articulations. We're looking at the joints of the human body, okay, the articulations. And so as you see here in the PowerPoint, so it says here joints, sites where bones and cartilage form a connection. And this connection many times will allow for movement, but not all of the time, okay, but it will many times. And when you think of, as you are still learning about the human body and such, when you think of a joint, you're going to think of a synovial joint, a joint that is moving and it's freely movable. That's the kind of joint that you're going to be thinking of. But there are multiple types of joints, and I want you to be aware of that. So you'll see here first that there's two ways to classify joints, articulations: structural, via structural classification, and via functional classification. We're going to start off with functional classification based on the amount of movement between the articulating bones. So the functionality of it, okay? Structurally deals more anatomically what's going on as far as the structure of that joint, okay? So let's look at then, so I'm going to minimize this for a moment, what we have here on our screen. Well, yeah, actually don't. I'll go here and then I'll go to the notes. So here you're seeing, as far as structurally, there are three classifications. Functionally, there are three classifications. Okay? So structurally, you're looking at fibrous, cartilaginous, and synovial. Again, when you think of a joint, you're thinking of the synovial joints. These are fluid-filled, hollow joints that have a lot of movement. That's what you're thinking of when you primarily, and your patients will think about them too, as far as they'll think of these synovial joints. Structurally, they are joints within a fluid-filled cavity. So it's this hollow cavity with fluid present, synovial fluid. It's the most common joint. But then you're going to see here that there are fibrous and cartilaginous joints. Not a whole lot of movement going on with the fibrous joints at all. And the cartilaginous, there's some movement, but again, not a whole lot. Fibrous, there's really not much movement at all, okay? But the cartilaginous, there's a little bit of movement going on. Synovial, freely moving. So this is structural classification of articulations. And you're seeing here that, so with the fibrous structural classification, fibrous connective tissue is what they're joined by, these bones. And again, when we're thinking of articulation, we're thinking of a bone and a bone connected via some type of soft tissue. Cartilaginous is joined by cartilage. So you're seeing here, as far as in that cartilaginous joint in the middle, it's an intervertebral disc. That is fibrocartilage that's joining those two vertebral bodies, right? Fibrocartilage, very strong, durable cartilage. Hyaline cartilage or fibrocartilage regarding cartilaginous joints. So these are, again, structural classifications. Then we go to functional classifications. We're going to have a synarthrosis, an amphiarthrosis, and a diarthrosis. It's the next slide. That diarthrosis, or that diarthrodial joint, that's what you're thinking about when you think of joints also. Your patients will think of these joints that are freely movable joints, okay? So let's take a look here and look at first synarthrosis, little to no movement. So the sutures of the skull, little to no movement. And amphiarthrosis, there's just a little bit of movement going on there, an amphiarthrosis. So the pubic symphysis, intervertebral disc are considered amphiarthroses. And then thirdly, as far as from a functional classification, we have diarthrosis or diarthrodial. This is a whole lot of movement, right? There's quite a bit of movement that takes place. Freely movable joints, diarthroses. Now, what did you see when you saw, as far as the functional classification? Functional classification, you saw S-A, what? D, SAD. That pretty easy to remember, right? SAD. Synarthrosis, amphiarthrosis, diarthrosis. SAD, SAD. That's the functional classification. Again, the structural classification, fibrous, cartilaginous, and synovial. I don't have an easy one for that, so. But you know what though, when you think of the synovial joint, that's the primary joint. the synovial joint. That's that freely movable joint. So when I say a joint is a synovial joint, are synovial joints also diarthroses? Yes, they are. Okay, so that's what you also need to realize. Now, let's minimize this for a moment and let's pull up the notes, that one-page notes. And so I'm not putting it up on here, but you all are seeing it here, and I have it on my computer that I'm recording on. Okay, so let's look first at the functional classification. So that's very simple and easy. SAD, and so we have immovable, slightly movable, and freely movable. Okay, does that help you? Immovable, slightly movable, freely movable. SAD. Okay, then we have, going above, the structural classifications: fibrous, cartilaginous, and synovial. Now, you'll also see that it's not just that simple, because there's classifications in each one of those. And so let's talk about that. So now we're going to go back up to the structural classifications. So let's look at the fibrous joint first. Fibrous connective tissue. Well, on my note packet, you'll see here that there's suture, syndesmosis. So look at this paper right here. Suture, syndesmosis, and agomphosis. So should your teeth be moving? Well, maybe if you have like scurvy or any other kind of issues going on, but they should not be moving, right? They should not be movable. So that's a tooth in a socket. So you have the mandible and the maxilla, and they all have alveolar processes. Do you recall that term, alveolar processes? That's the ability for a tooth in a socket, right? Whether it's maxilla or mandible, okay? Syndesmosis. So bones connected exclusively by ligaments. So the tibia and the fibula, that distal articulation. So the tibia and the fibula, the distal articulation would be at the lateral malleolus. Understood? So that would be then distal articulation, tibia, fibula, syndesmosis. That's an example of, okay? Bones connected exclusively by ligaments and really and superior up above it. So it's kind of like a band of tissue of ligament connecting bone to bone, right? Ligaments connect bone to bone. Muscle are connected to bone via tendons, okay? But ligaments, bone to bone. So syndesmosis, it's a fibrous joint. Should there be much movement going on? No, okay? So let's go down to cartilaginous joints. They're held together by cartilage. So we're thinking synchondrosis and symphysis. So you know what the pubic symphysis is, right? Fibrocartilage, is it not? Right, at that pubic symphysis. Synchondrosis. Now you have a couple examples here. A bar or plate of hyaline cartilage unites the bone. Hyaline cartilage. So an epiphyseal plate, which is known as the growth plate, that is a synchondrosis. The first rib to the manubrium, synchondrosis, right? Those are the examples. You need to remember, you need to commit to memory examples of these different types of joints. These are different types of articulations. And then lastly, and so the symphysis joint also, the intervertebral joints, right? Fibrocartilage. Now, synovial joints. These are the ones that you have to, it'll take a little bit more of a challenge because you're going to have to remember which joints in the body that are freely movable would be an example of these synovial joints. Now, let me go back to the PowerPoint for a moment here. And I know that I talked about this before, and I'm going to go on here in just one moment. Here we go. This is slide number 30. right? You will need to be able to draw that from memory, the synovial joint, okay? All the structures that compose that basic synovial joint. Remember, it is a hollow joint that's fluid filled. A synovial joint is a hollow joint that is fluid filled. And so you will need to be able to draw this from memory as far as the different components of it. Understanding that there's a synovial membrane, that is the inner lining, and that synovial membrane produces the synovial fluid. Okay? Right. Now, you'll see also that synovial joints are diarthroses or diarthrodial joints.
This conference will now be recorded.
All right, folks. So let's now go back into the PowerPoint and keep this handy so that you're able to look at it. You'll see there that, again, we talked about lastly, as far as those synovial joints, the different types. You'll see the 6 types of synovial joints. You will need to be able to, again, reproduce that image of the synovial joint from memory, okay? So that'll be important for you to start doing that now, okay? But this one page right here has a lot of information on it, and many questions can come from it, just this one page, okay? So please really work at learning that page, please, okay? Let's see here, okay. So I'm gonna go back up. And what we're gonna see in the PowerPoint are just examples of the different types of joints. Yeah, so I'm going to go back. I'm going to start with slide number 7. As far as that diarthrodial classification. Because again, this is really so important, because when you as a first-time learner regarding anatomy and physiology and the study of the articulations, this is really what you're thinking about, are diarthrodial synovial type joints, okay? So from a structural classification, the synovial joint; from a functional classification, that diarthrodial joint, right? So you'll see here uniaxial, biaxial, and multi-axial. And you'll see on my notes here, I've also given you that information for the synovial joints as far as the type of movement and such. And you'll see uniaxial, one direction; bi would be what? 2, so 2 planes. And then multi-axial is going to be in 3 planes, right? So you're going to think shoulder, hip, right? So the ball and socket, the 2 ball and socket joints, multi-axial joints, okay? So the structure, now this is really an important statement here. The structure of a joint determines which types of movement are possible. So do you see how the structure dictates the function? We've said that from the beginning, right? Structure dictates function. And I had given you as far as synovial joints, diarthrodial joints, or diarthroses. Fibrous and cartilaginous are functionally, right? Structurally, they're fibrous and cartilaginous. Functionally, they are synarthroses and amphiarthroses. So here we have fibrous joints in the PowerPoint. Here we go. All right, so fibrous joints, no joint cavity, right? So very much different from a synovial type of a joint, a diarthrodial joint. No joint cavity. They're not hollow, right? The joint itself. There's no fluid in the joint. There isn't that. So when you're looking at a suture, when you're looking at that syndesmosis between radius and ulna between fibula and the tibia, okay? That's what I was meaning, that web between. I misspoke earlier there when I said about the distal articulation. Primarily, it's really just between the two bones. That fibrous connection, that ligaments that are connecting the two bones, that would be that syndesmoses. So again, radius and ulna, or you can say tibia and the fibula, both examples of. And a gomphosis, a tooth in a socket, that alveolar process, in whether it's in the mandible or the maxilla, gomphosis. Fibrous joints. Suture type joints, right? So joins the bones of the skull. And we saw those in the first practical, right? As far as the different sutures that are present. So know this, that are those sutures in a child fully locked in place? They cannot be, right? That would be very bad. Can that kind of situation occur? And then they need to do surgery and such? Absolutely. But really, no, they should not. They should, there's allowing for movement and growth of the brain, right? So this cannot be. Classified as a synarthrosis may allow some slight movement. Understand that. There are even some practitioners who will try to manipulate suture joints and such. Not a wise idea, you know. That's something that could go wrong, that I don't know that that's wise to do. We can do many other things. Manipulating the suture joints is really not one of them, and I think is a wise idea. That's my own professional opinion. Everybody's got their own professional opinion on things, but that's my thoughts on that. You'll see here, form when skull bones completely ossified during early childhood. Take a look at, as far as fontanelles are present, the soft spots are present to allow for growth, right? Growth of the skull bones, growth of the brain, okay? Syndesmosis. So, joins two parallel bones using fibrous connective tissue. Okay? So this is important. So as seen here, as far as the space between bones may be narrow or wide, the wide spaces are filled with an interosseous membrane, connective tissue membrane. Functionally, they're classified as a amphiarthrosis. So there's a little bit of movement that takes place, found between the radius and the ulna and the tibia and the fibula. Again, the gomphosis, this is the tooth in a socket. Maxilla in the upper, the superior jaw, mandible in the lower. Cartilaginous joints. So we're thinking of hyaline cartilage, we're thinking of fibrocartilage. All right, so here we have cartilaginous joints. Bones joined by hyaline cartilage or fibrocartilage. Synchondrosis, hyaline cartilage. So can we say that, like we said before, the epiphyseal plate, the growth plate, right? Can we say the pubic symphysis as far as for fibrocartilage? Can we also say for the intervertebral discs, fibrocartilage, right? So, synchondroses, hyaline cartilage, right? So you're thinking epiphyseal plates, costal cartilage between the ribs, okay? Actually, not between the ribs, but really adjacent to, alongside of the sternum, manubrium, body, xiphoid process, right? Symphysis joints. So think the pubic symphysis, the intervertebral symphyses, right? Little movement, not a whole lot of movement, limited movement. Now here we go. As far as synovial joints, these are synovial joints. That is their structural classification. Their functional classification would be diarthroses or diarthrodial joints. Again, we looked at this before, but again, knowing and being able to commit from memory to write this down, to copy this, as far as an example of a basic synovial joint, this is a hollow fluid-filled joint, synovial joints. And you have, of note also, does bone rub on bone? Bone, healthy joints? No, right? There is articular cartilage at the ends of bone, and the articular cartilage is hyaline cartilage, okay? Ligaments and tendons, we get that as far as bone to bone, ligaments, muscle to bone, tendons. A menisci, right? So meniscus, very strong fibrocartilage. Protection, so you think the medial and lateral meniscus of the knee. Very strong, durable cartilage. It's fibrocartilage. Bursa and tendon sheaths. Bursa, so there are bursa throughout. And so have you ever seen someone who has had on their elbow, right, the olecranon process, kind of seems like it's kind of puffy and swollen, right? That is a bursitis of the olecranon bursa, okay? It's really, but it's like puffy and such because it's fluid filled. That's a bursitis. It's an inflammation of the bursa. Okay, that's one example. And here we'll see as far as fat pads, these are also cushioning type structures. Bursa and tendon sheets. So you're seeing here as far as bursa, small sacs of synovial fluid. Okay, you're seeing examples on this image here. Tendon sheets, they're elongated and they allow for movement. So they wrap around tendons where they cross a joint and allow for mobility. So free movement. Tendon sheaths. Their function, so look on the bottom, reduce friction between bones and muscle, tendons, or skin. So do you see how they, bursa and tendon sheaths, aid in the free mobility, the free movement of a joint? Now this is an easy one, the pivot joint, right? So you have the dens of C2 and C1, that oval shaped bone, right? So that pivot point there, that would be C1, C2, pivot joint. Where else do you think this might occur? How about the radial head? The radial head, the head of the radius. Remember how that has that ear and it kind of can pivot also? There can be a little bit of movement there. That's also a pivot type joint. Take a look at it in the lab the next time we're in there, right, as far as the radial head. And it's really inferior to or distal from, articulates with the capitulum. Remember the cap on the head of the radius. Uniaxial joint movement. A hinge joint. Well, we get this, right? We understand the hinge joint, right? You've got ulna. Ulna has that trochlea, right? And then the trochlear notch as far as for the ulna and the humerus, right? Allowing for this type of action, that hinge joint action. Also think the ankle and also interphalangeal joints, right? Hinge joints. Condyloid joints. So here we have, where would this be? So where, as you're looking at that, you're going, where's that? Well, what's carpals are the wrist. Metacarpals is the what? The palm of your hand. So that's the metacarpal, and that's the metacarpal phalangeal joint, is it not? And so this would be condyloid type joints. Biaxial joint. Next, the saddle joint. So think here, number one, pollex, number one. So a biaxial joint, two movements. Also the sternoclavicular joint, where the sternum and the clavicle articulate, right? Sternum, the manubrium of the sternum and the clavicle, also a saddle type joint. A plane joint. Plane joints, P-L-A-N-E, right? You're looking at surfaces of the bones are mostly flat. How about also intervertebral, right? As far as the superior articular process and the inferior articular process, flat, right? Think a plane joint. Here you're looking at the carpal bones and the intercarpal joints, plane joints. Ball and socket, very easy, right? The hip and the shoulder joints. The head of the humerus and the glenoid cavity. The acetabulum and the head of the femur, right? Multi-axial, multi-movements, multiple main ranges of motion there, great range of motion. Now this next image here, what is arthritis, right? So if you'll look at our note packet then also, so our note packet that was stapled and it had articulations on the front. And then what did you see from there? You saw, then there were going over a range of motion, going over the additional structures present within joints, and then we get to common joint injuries. And then on the back page, arthritis. All right. So inflammation of a joint. So arth, right? That word root, arth, joint. Inflammation of would be then the itis. Leads to pain, swelling, stiffness, reduced mobility of the joint. Folks, osteoarthritis is a degenerative joint disease, DJD. Degenerative joint disease, osteoarthritis. It's the wear and tear arthritis, folks. Degeneration of the articular cartilage. What can also cause joint damage? So you're seeing there gout, right? This is in my family as far as with my brother is concerned. And this gout is just horrible. It's an inflammatory process that is can be extremely painful. Diet can affect this. Genetics can affect this, being genetically prone. You'll see here autoimmune conditions, right? So the body where so like think in terms of like rheumatoid arthritis, rheumatoid variants and such. These are all going to be affecting the joints from an autoimmune function where the body is attacking itself. Joint infections can also lead to this. Genetic causes, right? Genetic predisposition. And you're seeing as far as the breakdown of a joint and how we can end up having no cartilage that's buffering, right? That's allowing for cushioning, and fusion of joints it could lead to the damage of these joints. Here you're just seeing as far as an example regarding of a hip replacement. I mentioned to you all, I shared with you that my mom had a knee replacement only just last week, actually. And it's quite remarkable. She's 81 years old and she's getting around and it's amazing, really. I'm looking at a knee replacement down the road. At this point in time, I'm good. I don't need it, but I know that, it's inevitable. So, now with how good the technology is, and it's only ever improving, which is really great. These hip replacements, these joint replacements, they can last many, many years in comparison to what they did years ago. So it's really incredible what they can do. All right, these synovial joints, these diarthrodial or diarthroses, freely movable joints. So when we talk about range of motion, right? Range of motion, we're talking about the movements that can take place within a joint. So you need to know this as far as what is flexion, what is extension, what is hyperextension, lateral flexion, right? So these are different. So if you work in a general practice, if you work in an orthopedic practice, if you work in a neurologist's office, right? So neurosurgeons, these are things as far as dealing with joints. How about a practice that takes care of auto injury or workman's compensation injuries? Are we concerned with chiropractors? Are we concerned with range of motion? Right? Absolutely. Yep. And know this, that when there is decreased mobility, there is going to be more decay of a joint. It's going to lead to degradation of joints. I'm Excuse me. I'm looking at my mic because I forgot to charge it, and so it's still going. So that's a good thing. I'm sorry. Here you're seeing example of flexion, extension, hyperextension. And we can measure these movements. It's very important because if we can do this, then we can say, hey, we know what normal should be, and the patient is measuring at blank. And if it's less than normal, then there's been some type of compromise to the joint. Now, abduction. So think about this for a moment. If I abduct someone, right? Terrible thing, but if you abduct someone, you're taking them away. So now come over here and look at this. Abduction. Abducting my arm, I'm taking it away from the core. Am I not? Abducting. How about my fingers? Abduction. Now, adduction would be what? Going back. Adduction. Abduction, abduct, away. How about my leg? Abduction. Adduction, right? Circumduction is movement in a circular motion. So what can circumduct? Diarthrodial joints that are multi-axial. So shoulder, hip, that can be circumduction. Flexion, abduction, flexion, adduction, extension, abduction. Multiple forms of range of motion in that circumduction. Rotation, you get this, you understand rotation, right? A twisting type movement. Supinate and pronate. So here we go. Supination, pronation. Supinate, pronate. Now think about this for a moment. If I'm supine, here's supination, I'm on my back. If my patient, I ask my patient as a chiropractor, lay on your back. I'm putting them in the supine position. If they're on their stomach, they're in the prone position, not the prone position, the prone position. They're on their stomachs, right? They're in the prone. Are they prone to someone coming and scaring them? Boom, right? That's how I kind of think of it that way, prone. Prone position, they're on their stomach. But if they're on their back, they're in the supine position. So supinate, pronate. Dorsiflexion and plantar flexion. So plantar fasciitis. Plantar fasciitis, sole of your foot, right? Sole of your foot, there's all kinds of tightness going on, can lead to heel spurs and such, pain, discomfort, no fun. Never fun, right? So, but you think, so plantar fasciitis, so what direction am I moving my foot when I'm plantar flexing, right? Inferior word. Dorsiflexion, superior word. Inversion, you're going inward. Eversion, outward. Inversion, eversion. To protract and retract. This can be for the mandible. It's easier to think about it with the mandible than it is with the scapula, but both can protract and retract. Now, how about depression and elevation? Mandible and scapula again, right? So this one is easy though. So depressing if I elevate the scapula. Look at this, right? Elevate the scapula, right? Depress the scapula, right? Or yeah, elevate and depression, scapula, that's easy. And what do you think would assist in the elevation of the scapula? Levator, what? Scapulae. You saw that today in the lab. Depressing the mandible, elevating the mandible also. So mandible and scapula for protraction, retraction, depression, elevation. opposition and reposition. So we have opposable thumbs, do we not? Right? Just like what? The primates and such can have that, okay? And honestly, it doesn't mean we're related. It just means that they have that ability to do the same type of range of motion we do. All right, anatomy of selective synovial joints. I think we're gonna, you know what, let's see. I'm gonna hold off here. I'm gonna stop here for tonight. Yeah, I'm gonna stop here for tonight. We'll move on from on next class.